I'm Dr. Stephen Silberstein, Professor of Neurology at Thomas Jefferson University and Director of the Jefferson Headache Center. Today I'm going to be talking about migraine pathophysiology and calcitonin gene-related peptide, or CGRP. On this slide are my conflicts of interest. Migraine is more than the headache. The premonitory symptoms that can occur a day or so before the headache, the aura, which are neurologic symptoms, can occur right before the headache itself, and then the postrum. So we see the following. The premonitory phase is associated with yawning, fatigue, depression, neck pain, sensitive to light, to sound, and to odors. The aura, which occurs in only a minority of patients, can be flashing lights or even funny sounds or odors. The headache and the postrum, fatigue, depression, photophobia, nausea, and allodynia. And afterwards, between headaches, patients can have increased sensitivity to light. Things that shouldn't be painful could be. They can have a mild headache and have difficulty thinking. Let's talk a bit about the aura. On the screen is a typical migraine aura. On the edge, you see the flashing blue light. In the middle is an area of no vision at all, and therefore it's called a scintillating scotoma. What's the aura due to? We think it's due to neurological dysfunction, not due to ischemia. These really resemble those due to direct brain stimulation. And we think it may be due to something called cortical spreading depression. What is cortical spreading depression? Leo, many years ago, looked at the reactivity of the cortex. He hit point 0, stimulated the cortex, and he found out that electrical activity was wiped out. And with the passage of time, this loss of electrical activity spread across the cortex, hence it's called cortical spreading depression. The next step is, what causes the headache? What's sensitive? And we know the scalp, parts of the lining of the brain, the arteries and nerves themselves, and the head and neck muscles are sensitive to pain. So then what causes headache? Any of these pain-sensitive structures that are tensed or displaced, the arteries, if they're inflamed, if spinal fluid pathways are obstructed, and in part it could be primary central pain and involvement of the pain modulating system. So we look at the anatomy of migraine headache. It's the trigeminal nerve, the dura mater, the trigeminal ganglia, and the feedback in the brainstem to the trigeminal cervical complex. Harold Wolff believed that the migraine aura was due to intracerebral vasoconstriction. The headache was due to reactive vasodilatation. The pain was enhanced by peptides, and this would explain the throbbing nature of the pain, its varied location, and its relief with ergots. But it's not really supported by recent blood flow studies. Jess Olson looked at migraine without aura and found no change. With aura, he found a wave of bulimia, or decreased blood flow, that began in the back of the brain and moved forward at a rate of 2 to 3 millimeters per minute. Begins with the aura and persists for hours after the headache. It's not in the distribution of any artery, and this really looks like cortical spreading depression producing secondary vascular changes. Why does the headache pulsate? The concept is that there are inflammatory mediators released during migraine that actually sensitize peripheral and central neurons. And the pulsatile pain is believed to be mediated by the fact that these meningeal pain receptors become hyperactive and respond to the pulsating of spinal fluid. So how does cortical spreading depression trigger headache? That's the question. One of the concepts is the following. You have a wave of cortical spreading depression, and it actually activates axons innervating the meninges and results in inflammation, vasodilatation, as a result of the release of chemicals producing the pain of a migraine headache. So in many ways, migraine headache is really reactive inflammation of the nerves surrounding the brain in the meninges, the dura, and the pia. So, what's the evidence for this? If you take and produce a wave of cortical spreading depression, and you put an electrode in the trigeminal nerve, you can actually find that potassium chloride produces trigeminal activation after a delay, and that delay correlates the time why it goes from the aura to the headache. The cortical spreading depression, by putting potassium chloride in the cortex, can actually produce cortical spreading depression, which then can activate dural trigeminal pain fibers. What's also interesting is the following. A number of years ago, Diener's group looked at imaging of patients during migraine, and what they found that the PET scan demonstrated activation in spontaneous migraine attacks. It persisted after headache treatment, and there's been a question whether this is a brainstem generator or modulator. We're still not sure. So, we think migraine is a neurovascular pain disorder. Referred pain from the dura mater and the blood vessels. There's neurogenic inflammation, leakage of proteins, and sensitization of these nerve fibers. And there's centrally, there could be pain modulation and central sensitization, which means that neurons now respond to the rest of the body. That may explain why patients with migraine can't touch their hands or their head because of so-called central sensitization and allodynia. And one of the interesting phenomena is this older study from Irene Tracy. She put a patient in the magnet, put a noxious stimuli, and distracted them. The one with the red shows that the brainstem is lighting up. Patient felt no pain. On the other side, the lighting up is gone. She had them pay attention to the pain. The red light went away, and you know what happened? They felt more. So the body has the ability, through the periaqueductal gray, to modulate pain. So we think that migraine is a neurovascular pain syndrome. There's central facilitation, the hypothalamus, the prodromes, the feeling of tiredness or neck pain probably originates in the hypothalamus. The aura probably is cortical spreading depression in a hypersensitive cortex. The headache itself is probably referred pain from the lining of the brain and the blood vessels. The aura activates meningeal nociceptors, but in addition, parasympathetics may do the same thing. When the meningeal nociceptors are activated, there's neurogenic inflammation, leakage of proteins, peripheral centralization, and then the headache is continued by the sensitization of central neurons. Now, what about neuropeptides? A number of years ago, Goatsby looked at neuropeptides in patients with migraine, and he found that calcitonin gene-related peptide was elevated, VIP occasionally, but substance P wasn't, in patients with migraine, suggesting that something was happening to these neuropeptides. Let's go back again to central sensitization. It's an immediate onset, activity-dependent increase in excitability of painful neurons. It results from an outlast intense input. And basically, there's a whole bunch of things like substance P and BDNF and can actually intracellular signaling modifiers. And as I showed you before, these are neuropeptides that increase during the migraine attack. So the concept is that in the peripheral nervous system, the neurons continue to be activated. They send impulses to the wide dynamic range neurons in the brainstem. These can be modulated, and then they become overactive, as a result of which information from non-painful A beta fibers go to these same wide dynamic range neurons, and this input is perceived as painful. Now, Rami Burstein had a very interesting concept. He thought that the triptans may work the following way. He thought they may work by blocking the release of chemicals, including neuropeptides, from nerve endings. So if you look at the upper screen, you have the dura, you have a sensitized blood vessel, and it activates central neurons. That accounts for the pain and the throbbing, but no allodynia because there's no sensitization centrally. If you give it triptan, you block the release of chemicals from the nerve, the pain goes away, the throbbing goes away, and you don't have to worry about allodynia. After these central neurons are sensitized, you now have pain, throbbing, and allodynia. If you give a triptan, allodynia persists because the neurons are still sensitized, the pain is diminished, but the throbbing's gone away. This is probably how these medicines work for the treatment of migraine. So let's go back to calcitonin gene-related peptide. It's widely distributed in the trigeminal system. It's released along with substance P and glutamate, and antibodies to CGRP or the receptor can interfere with interactions. So let's just reiterate what I showed you before. I showed you that CGRP is the only neuropeptide that's increased during a migraine attack, and if you then give sumatriptan, the CGRP is normalized. So here you have CGRP baseline increases during a migraine attack and then is normalized. The other interesting phenomena is the fact that if you take a patient and you infuse CGRP, you get an immediate headache which resolves. Then after a number of hours, these same patients get a delayed headache which is very, very, very much like migraine. This is the mechanism of inducing headache by giving CGRP. So we know that CGRP infusion triggers migraine, and the levels increase during migraine and decrease with headache relief. We know that triptans inhibit CGRP release, and the CGRP receptor antagonists can block CGRP, inhibit pain transmission, but are not themselves direct vasoconstrictors. So we have a CGRP receptor that's blocked, and by giving an antibody or a small molecule, we can turn the process off. So let's talk a bit about the calcitonin family of neuropeptides. And they consist of calcitonin, which is responsible for calcium metabolism, amylin, CGRP, and adrenomedullin. The original function of CGRP was maintenance of vascular homeostasis, and now there's a new role in pain control. CGRP exists in two forms, the alpha form and the beta form. The alpha form is mainly in the brain and in neurons, and the beta form is mainly in the gut, the so-called enteric or gut nervous system. So, CGRP is a 37 amino acid neuropeptide. It's the most abundant peptide in the dura and the trigeminal ganglia. It's in C fibers, that's very important. It's not in A delta fibers, it's in C fibers. It's released with glutamate by activating the trigeminal nerve, and it produces vasodilatation, mast cell degranulation, and responsible in part for sensory transmission. What's it do? Pain modulation. It potentiates the release of other peptides. It promotes painful transmission. It modulates the transmission of glutamate and acetylcholine. In the periphery, it produces vasodilatation and mast cell degranulation. In addition, it can excite nerves and glial cells and stimulate its own synthesis. As complicated as CGRP is the CGRP receptor. CGRP receptor reminds me of a Chinese restaurant menu. Get one from column A, one from column B, but in this case, there's one from column C. So the receptor consists of the calcitonin-like receptor, a receptor complex protein, component protein, and RAMP1. And if you stimulate it, it activates cyclic AMPs. Here is the CGRP receptor. It consists of the calcitonin-like receptor and RAMP1. The adrenomedullin receptor is the calcitonin-like receptor and RAMP2 or 3. The calcitonin receptor is calcitonin alone, and the amylin receptor is the calcitonin receptor and RAMP1. So these different receptors are a combination of the RAMP1, 2, and 3, and the calcitonin receptor-like receptor, and the calcitonin receptor. Now what's interesting is the following. You have the CGRP receptor and the amylin receptor, both of which use RAMP1. So it looks like CGRP actually goes to two different receptors, the CGRP receptor and the amylin 1 receptor. What is the amylin 1 receptor? It's formed by the CTR and RAMP1, has very high affinity for CGRP, it's present throughout neural tissue, and actually people use a lot of this. There's a pancreatic hormone, it's co-secreted with insulin, and there's actually an analog which is used with insulin to slow gastric emptying. We do not know yet what the function of amylin is in the brain. So as I say, there are two CGRP receptors. The amylin hits its own receptor with a potency equal to CGRP, and the CGRP receptor is much more potent in its own receptor than amylin. So now we're dealing with the fact we have one neuropeptide, two receptors, and another neuropeptide, just one of the two receptors. Now, what's very interesting is a new study about looking at one of the monoclonal antibodies. And the concept is the following. You have these C fibers that contain CGRP. You have the A delta fibers. They contain the receptor. So it turns out the monoclonal antibodies actually work by blocking the affinity of released CGRP from the C fibers going to the A delta fibers. Very, very interesting and very important observation. In contrast, we believe botulinum toxin type A works from the C fibers directly. And here's the simple way of looking at it. On the upper left is cortical spreading depression. There's the pia under it. You have activation of the C fibers, which release CGRP. Then you go to the RAMP1 CLR complex and the A delta fibers, which activate the high threshold neurons and by relay the wide dynamic range neurons. So the CGRP monoclonal antibodies, there's an independent activation of the wide dynamic range pathway through the C fibers, and it's blocked by the antibody, the CGRP-dependent activation of the A delta high threshold pathway. What does this mean? It means the fact that there are two different routes from pain, one through the C fiber, one from the A delta. C fibers release CGRP, which can go to the A delta fibers, which are blocked by the antibodies. And there are two different independent pathways of that for pain getting into the brain. Thank you.